We're ready to begin the afternoon session. We have 4 different talks that range from managing adnexal masses and screening to how to take care of women in under-resourced areas. Just a reminder to silence phones and pagers. Again, the reminder about the CME credits, you need to do that online if you want CME credit, and there should be a link for you for that. And again, if you need anything during the session, you can either find me or one of the course directors who are just outside in the lobby. So our first speaker of the afternoon is Dr. Taima May. She is a recent return hire to our division. She was a fellow with us, probably 10 years ago, I think. Can't remember, maybe 15 years ago. I've been practicing to an oncologist in Toronto, and we're very fortunate to recruit her back to be one of our members of the faculty. She's a fantastic surgeon, and we're just so pleased that she's in our group again. She's going to talk to us about the management of adnexal masses, whether you should observe, intervene, or refer. So without further ado, Taima. So this is your slide of answer and then a pointer if you want it.
Perfect, thank you. Good afternoon, a little bit lower. Good afternoon. Thank you very much for the opportunity to present. So today we're going to talk about a very common issue that a lot of us deal with both on the oncology side and the benign side. So when you referred a patient with an adnexal neoplasm, how do you know if it's serious? How do you know if it's significant? And what do you do to help manage this patient? I have no disclosure. I am an author for UpToDate about this same topic, so hopefully you'll find this relevant. So objectives, we're going to talk about introductions to types of adnexal neoplasms, differential diagnosis, clinical assessment, investigations, appropriate referral, surgical planning, intraoperative management, and how do we optimize outcomes for these patients. So the adnexa really is this triangle structure where the ovary is, the fallopian tube, the broad ligament, and a lot of the neoplasms usually arise from this structure. So it's present in about 8% of people who are premenopausal and 2.5% of patients who are postmenopausal. Over a lifetime, a woman could probably undergo surgery for an ovarian mass, about 5% likelihood that a patient would undergo surgery for this reason. So differential is very broad. If you look at the ovary only as a source of the adnexal neoplasm, simple physiological cysts are very common. We all obviously have those, and when we follow them with ultrasound, they regress as time goes on. Hemorrhagic cysts, very common. Endometriomas, which sometimes are challenging to differentiate between an endometrioma and actual neoplasm. Theca lutein cysts, benign neoplasm, borderline, malignant primary ovarian tumors, and of course metastatic carcinomas, often from GI tract, which we call Krukenberg tumors, and sometimes from breast or other tissue. Extra ovarian masses, so in the adnexa, but not primary from the ovary, ectopic pregnancy, which obviously is often an urgent diagnosis, hydrosalpinx, para-ovarian cyst, peritoneal inclusion cyst, often in our patients who've had prior surgeries, either prior cystectomies or multiple previous pelvic surgeries, so they have adhesions, and you do sort of struggle with what to do with these inclusion cysts. Pedunculated fibroids, often, especially if they're in the broad ligament. Pelvic kidney, which is very rare but very serious. You obviously don't want to be in a situation where you're thinking it's an ovarian neoplasm and taking out somebody's solitary kidney. That would not be ideal. Appendiceal tumors, and then fallopian tubes cancers, which are rare but quite serious diagnosis. So the ovarian neoplasm, so when I see a patient with this diagnosis, I will tell them a tumor is basically a collection of cells. What type of cells are growing within that tumor is the most important feature of how do we manage it. There are obviously a lot of details, but generally speaking, there are 3 components to the ovary. There's the capsule, which is the epithelium. There's the germ cells, which of course are the eggs. And then there's everything in between, the connective tissue, the blood vessels, and everything that sort of is in the parenchyma of the ovary. And any one of those 3 components could become neoplastic. So it could be benign neoplastic process, meaning not a cancer, never will become a cancer, but potentially could cause surgical problems, pain, bleeding, and other issues where that needs to be addressed by a general gynecology surgeon to help alleviate those symptoms. On the other extreme, there's cancerous tumors. So those, of course, are malignant, and they need to be removed to help improve outcomes. And then in between, there's borderline tumors, pre-malignant, low malignant potential tumors, which, unlike benign tumors, have not invaded the basement membrane yet. However, they have the potential to potentially become malignant, and often low-grade malignancy. So the most common within the ovary are epithelial tumors, many different subtypes: serous, mucinous, endometrioid, clear cell, transitional cells, and those comprise about 85% of all tumors we deal with in the ovary. Germ cell tumors could be sort of these in younger patients. So oftentimes, if somebody's young enough to get pregnant, I usually will send germ cell tumor markers just to be sure it's not a germ cell neoplasm. Dysgerminoma, yolk sac, embryonal carcinoma, choriocarcinoma, and teratoma are the most common. Of course, teratoma is the benign germ cell neoplasm, which is a dermoid, and that is the most common tumor we do see in the ovary. Then sex cord stromal tumors are everything sort of in between, the weird and wonderful, as we say. Granulosa cell tumor, which are malignant but indolent, fibroma, Sertoli, Leydig cell tumors, thecomas, and so forth. Of course, there's very, very rare sarcomas as well that can arise here. So when we look at ovarian neoplasms, there's type 1 and type 2. When we look at the epithelium, which is the capsule, and those comprise 85% of all ovarian tumors. So when we look at type 2, which if you sort of Google ovarian cancer, that's the one we usually look at, which is the high-grade serous ovarian carcinoma. It is the most aggressive form of ovarian cancer. We now know that we call it ovarian cancer. However, genomically, it is from the fallopian tube. So the fallopian tube epithelium sheds on the ovary and creates these larger tumors in the ovary. Therefore, we label it as ovarian carcinoma, but it is fallopian tube or primary peritoneal. They're all treated the same. There has not been a precursor lesion of high-grade serous carcinoma in the ovary, but we all know that there are stick lesions which are precursor to carcinoma from the fallopian tube. Therefore, we obviously know that the fallopian tube is important to be removed if there's an ovarian neoplasm that is concerning for an ovarian carcinoma. Type 1 ovarian tumors, carcinomas tend to be from the ovary itself. They tend to be more in line with low-grade serous carcinomas, so different pathways for cancers, endometrioid and clear cell, which can arise in our patients with history of endometriosis, and then mucinous tumors. When we look at serous ovarian cancer, and there's two types of ovarian cancers, there's high-grade and low-grade, and it's important to sort of know the difference. Briefly, low-grade is a non-aggressive form of ovarian cancer, and those are not a spectrum. So it's unfortunate that they're both called serous ovarian cancers, but low-grade is not a precursor for high-grade, and high-grade was not a low-grade that has become high-grade. They're two distinct entities, different grades, different pathways, and obviously they're managed quite differently, and now we know that the mutations within them are different. The types of systemic therapy that patients benefit from is different between each. So we know that it's obviously we need to rule out a cancer whenever we think of someone with an ovarian neoplasm. Ovarian cancer is the 5th most common cancer in women, and it is the 4th most common cause of mortality. We know that most ovarian cancers are diagnosed at advanced stage. 70% of patients have stage 3 or 4. And the survival is quite poor, it's less than 30%. We're making some improvements, but not a lot. Stage 1 ovarian cancer, on the other hand, which is not very common, has a 90% survival. So head-to-head endometrium and ovarian tumors have similar survival when you look at early stage disease. We just haven't had the capability yet to diagnose ovarian cancer in earlier stages the way we can for endometrial cancer. So if you do see a patient and you are concerned that this could be an early stage ovarian cancer, it is important to make sure we try to manage them as efficiently and comprehensively as possible, because their survival could be very high. And this is one of the few times we don't want to miss the opportunity to treat them successfully. If patients are cared for by GYN oncology with ovarian cancer, their survival is better. Patients are seen by a GYN oncologist before they start treatment. The hazard ratio for improved outcome is 1.61%. and patients' mortality, if their surgery is done by a GYN oncologist, is improved by a hazard ratio of 2. So it's not inconsequential. We know that if the patient has surgery by the specialist oncologist, the rate of surgical staging is higher, rate of completion surgery, if they had a diagnostic surgery, is higher. The adequate selection for primary surgery versus neoadjuvant chemotherapy is more comprehensive. GYN oncologists are obviously trained to do comprehensive surgery for ovarian cancer. The rate of optimal outcomes is good, and then the timing between surgery and initiation of chemotherapy is lower. So we all know that it's helpful to have surgery by a gynecologist, and survival is significantly better if patients have surgery at a center with a GYN oncologist. Now, not all tumors are malignant. So if we can look back after the diagnosis, then we would know what to do. We can always predict the past. It's very hard to predict the future. Once you see somebody with an ovarian neoplasm, how do you know? Should I send them to a GYN oncologist? Because if it's malignant, the right thing to do is the surgery to be done by a GYN oncologist, as we saw. But if it's benign, there's sufficient data that we should not, or we should limit how many benign ovaries we remove. So there are adverse outcomes if we remove ovaries that are non-malignant. It compromises fertility, increases all-cause mortality, increases cause-specific death, including lung cancer, colorectal tumors, total cancer, coronary heart disease, cardiovascular disease. There was a study in the UK of over 100,000 women, and admission for ischemic heart disease in patients between 35 and 45 who had an oophorectomy for benign disease was worse if they've had an oophorectomy, and all-cause deaths was worse by 0.64 hazard ratio. So we sort of have to be thoughtful to say, what is the likelihood that this is malignant? The ovary is one of the few organs we do not biopsy ahead of time because the capsule is protective of the neoplasm. So unlike uterine tumors, cervical, breast cancer, and many of other tumors, we biopsy ahead of time and you know exactly what's the best trajectory for that patient. The ovary use other markers, surrogate markers, to say what is the likelihood that this is benign or malignant, and then you refer to the proper surgeon. If it's benign, the most beneficial surgeon is the gynecologic surgeon. If it's malignant, the most beneficial surgeon is the oncology surgeon. So there are protective factors we know for malignancy, pregnancy, breastfeeding, and oral contraceptives. I have to be honest, I've never used those factors because they're so common that it's very unlikely that you're going to say, oh, somebody had breastfed, therefore I'm not concerned about a cancer, but it's helpful to know. Risk factors, history of infertility. Endometriosis is a risk factor specifically for type 2 tumors, endometrioid and type 1 tumors, menopause, family history, and genetic mutation, specifically the BRCA mutation. When we look at signs of symptoms, a lot of times people call ovarian cancer the silent killer, but there's enough data that when you go back and sort of try to educate, try to find symptoms, they have been present, it's just they're vague. So education is very important both for the primary care providers and for the patients, that if they have symptoms, especially if they're persistent, it's an important issue to raise with their physician because it could be an indication of an early tumor. Pelvic or abdominal pain, increased abdominal girth or bloating, difficulty eating, early satiety, and that they're new in the past year, so somebody with chronic GI condition that has not changed is not as concerning, but somebody with a stable bowel function and suddenly have a significant change, that's a concern. And if they occur more than 12 times per month. Again, when patients look back, they can really recall those symptoms, but it's hard to put it together when they start. Clinical exam, when you see patients, is very important. If they have a lower BMI, if the BMI is over 30, sometimes it's limited by body habitus. If you feel a mass, especially if it's irregular, if it has solid parts fixed, this is one of the most concerning things. If it's fixed to the cul-de-sac, fixed to the pelvic sidewall, if it's nodular, bilateral, free fluid, obviously if there's clinical signs of ascites, that's a little bit more concerning that it's a malignant process. So blood work, tumor markers, we have epithelial tumor markers and germ cell tumor markers, and then sex cord, looking back at the three components of the ovary, you can check for each. And those are markers. They are suggestive, they're not diagnostic. CA125 can be elevated in many ovarian tumors, serous endometrioid clear cells. CEA can be elevated in mucinous ovarian tumors, endometrioid and clear cell as well, but also can be elevated in colorectal cancers. If it's significantly elevated, we would often recommend colonoscopy ahead of time to rule out a GI primary, and that would change the surgery. If you think it's an ovarian primary, you might do more staging and be more comprehensive. If it's a metastatic Ruckenberg tumor, you may just remove the metastatic tumor and not need to remove the uterus or do other staging procedures. CA19-9 can be linked to upper GI, so looking at pancreas and small bowel could be, of course, associated with mucinous ovarian tumors, endometrioid and clear cell. Upper GI endoscopy, if it's significantly high. CA19-9 tend to be very similar to CA125 in terms of inflammatory markers, so it can be very high in people who just have an inflammation. CEA is a little bit more specific. In my practice, I do all three together and sort of helps put it together. Oftentimes, if it's a mucinous tumor of the ovary and the CA19-9 is high, post-operatively, when the patients get chemo or so forth, that's the marker you follow. So if it's elevated at diagnosis and then trends down post-op and post-treatment, it's a very helpful marker to follow. Germ cells, of course, anything that can be high in pregnancy would be high in germ cell tumors, so LDH, AFP, and HCG are the markers we look for, and sex cord stromal tumors with inhibin A and B, often for granulosa cell tumors. CA125 is a glycoprotein. It's called MUC16. It's non-specific. It's inflammatory, and it can be high in pretty much most things that cause inflammation: pregnancy, endometriosis, adenomyosis, menstruation, benign ovarian cysts, fibroids, infection, non-gynecological conditions, and other malignancy. So it's only helpful to have it pre-op so you can monitor it post-op if, in fact, it is malignant process. It is very specific in cancer. So in hindsight, if a patient presents with a carcinoma and their CA125 is 1500, it doesn't mean it's malignant. But if it is malignant and you treat them and their CA125 normalizes and you follow them for several years and the CA125 rises, that's a very helpful marker that you can then do scans and diagnose them. So it's helpful for monitoring, it's not helpful for diagnosis. But because you can predict if they have malignant, we do it at diagnosis. Sensitivity of CA125 is more if it's advanced disease. So again, if it's advanced disease, usually you can see it on scans. You don't really need the CA125 to tell you, but it's helpful as a marker. For early stage disease, the CA125 positivity is only 50%. Other markers, HE4, for example, elevated in 80% of patients with epithelial ovarian cancer, rarely elevated in benign disease. More specific, in young women with benign disease, combined with CA125, increases the sensitivity. So some markers, some tests combine both, which can be helpful. OV1, there are panels that combine a few tumor markers. So if you have access to those, you might use those, which can be helpful. OV1 has several markers. Ovaria has HE4 and other markers, including FSH and CA125. The Roma just has the two, CA125 and HE4. All of them are approved for triage, not for diagnosis. Other tests, so multimodal testing, looking at imaging plus tumor markers. Classically, the risk of malignancy index has been used for a long time, so it's now not used much anymore now that we have more detailed testing. But when you look at the RMI, it's the basically features on ultrasound, menopausal status, and CA125, and you give those specific values. The sensitivity and specificity is over 80%. The Adnexal looks at multiple modal tests as well, looking at age, serum CA125, and importantly, the referral centers. So centers that have high volume tend to do better because the more you see something, the more likely it is that you will identify it and diagnose it with a sensitivity of 96%. Imaging modality, I think, are the gold standard of what we all use. Transvaginal ultrasound is the first-line technique for any ovarian pathology. Sensitivity is over 90%, specificity ranges between 50 and 97% to detecting a malignancy. The patterns of recognition approach is superior to other methods. It's cost-effective, it's non-invasive, it's widely available, and it is well tolerated by patients. So we'd usually recommend starting with an ultrasound to see what are the findings there. The limitations can be operator dependent. I think that's probably the most important. We all know that when a radiologist who's very familiar with this calls a concerning lesion, that's usually very, very specific, and we rely on their expertise for that. Technical factors and then patient habitus can sometimes limit the interpretation of the ultrasound waves. Sonographic findings suggestive of malignancy, solid component that are nodular or papillary, especially thick septations over 3 millimeters, Doppler flow, especially high Doppler flow, presence of ascites, of course, and any evidence of extraovarian or metastatic disease. MRI valuable only in select circumstances. If it's a solid mass, for example, endometriomas, sometimes it's helpful. Differentiate between uterine versus ovarian pathology if you're not quite sure. Mature teratomas, limited assessment on MRI with ORADs, which we'll talk about next. CT scan and PET scan have limited values with an isolated ovarian neoplasm unless you're trying to stage the patient or unless you obviously want to rule out metastatic disease. So evolution over time, the radiologists have started, for the last 30 years with the IOTA, with the different indices and then IOTA terms. And eventually, I think most of us now rely on the ORAD score, which was ultrasound-based and or MRI-based. So when we look at the ORAD score, the American College of Radiology came up with, in collaboration with the IOTA group, came up with the ORAD classifications of Adnexal neoplasm. The goal was to provide standardized, reproducible lexicon that includes all pertinent descriptions that characteristic of ultrasound appearances, normal ovaries, ovarian lesions, and other adnexal lesion. They looked at over 6,000 patients of the IOTA study and then went back and did risk assessment on those patients, and that's how the ORAD score came about. So the ORAD's ultrasound ORAD score, the aim is to improve characterization of ovarian pathology, consistent image interpretation and reporting, improve accuracy in determining risk of malignancy, and the ORAD's classification range from 0 to 5, 0 being not able to assess, so the actual scores are 1, 2, 3, and 4, and 5. A stratification of risk based on the size of the soft tissue element of the tumor, the number of soft tissue elements, and the vascularity. I think the biggest thing that I have noticed in practice since the introduction of the ORAD score is consistency. Before, it depends on which lab the patient went to, which radiologist. Sometimes you would get a very, very thin report which doesn't have a lot of details. Sometimes you get a very descriptive report without actual interpretation. And this is very helpful because it actually gives you an interpretation of a score. So 0 means incompletely evaluated, so you have to repeat it. 1 is a normal appearing ovary with just a cystic lesion, nothing solid, no tumor, so that's great, it's not a neoplasm. And then 2 is almost certainly benign. Less than 1% of ORADs, 2 tumors are malignant. 3 is low risk, so it's less than 10%, and the majority of those were pre-malignant borderline tumors. 4 is probably the toughest category because 4 is an intermediate risk for between 10 and 50%. So 10% is not high, 50% is quite serious. So which one do you follow? ORADS 4 is probably the most concerning, and a lot of the referrals are appropriate for ORADS 4, and that's where a lot of the counseling goes. ORADS 5 is high risk, 50% risk of malignancy, and those should almost certainly be managed by oncology. MRI score, similar to the ORAD scores, just using MRI as a modality versus an ultrasound, which is no longer operator dependent. So score 2 is, again, low risk, score 3 is low risk, score 4 is intermediate, and score 5 is high risk. So clinical benefits: earlier triage of patients with suspected ovarian cancer to gynecologic oncologists. So with an ORAD score, now we're not repeating ultrasounds as often for concerning lesions, decrease unnecessary removal of benign ovaries. So if it's an ORAD 2 or 3, you can counsel the patients that this can be followed conservatively, and then decrease unnecessary use of imaging, so less need for repeat images for benign conditions. So once you have this information, you see a patient, you do tumor markers, you examine the patient, you do an ultrasound, you have an ORAD score, so you can counsel the patient if it's reassuring, normal tumor marker, normal ORAD score, that they can be observed, especially if they are asymptomatic. So this talk is about the risk of malignancy, but oftentimes if a patient has a 12-centimeter mass that's an ORAD 3 or 2, it could be reassuring from a cancer standpoint, but the patient could be symptomatic from either pelvic pressure or pain or bleeding. So you might still recommend surgical excision for surgical reasons, not necessarily for cancer reasons, and that's absolutely fine. But from an oncological standpoint, it would be okay to observe. Refer anything that is concerning for definitely ORADs 5 and ORADs 4. I would recommend referring a patient. They may not need surgery with gyn-onc, but at least reviewing the scans, potentially doing an MRI, and then counseling the patients about the risk and benefit. Between 10% and 50% is quite wide range, so adding tumor markers, physical exam, and then potentially tailoring the recommendation to that particular patient might be helpful. Excising the ovaries, I always tell patients that once we proceed to surgery, it's for diagnostic and therapeutic purposes. So you'd get a diagnosis and treatment hopefully at the same time. Informed consent is probably the most important. A lot of us spend a lot of time talking to patients about the potential findings, the diagnosis, and then the potential upcoming surgery. Very important to document everything, especially in a diagnosis that is vague. When we have a patient with grade 1 endometrial cancer, we know exactly what surgery they need, we know what the staging is going to entail, and we can clearly write that on the consent. Here, when you think it could be malignant, it could be benign, it's going to be a lot of possibilities, and it's important to discuss that with the patient, to say, if this, we could do this versus that, what would be the patient wishes? And then put that on the consent and so forth. So as you start the operation, you do the metastatic survey, you'll get some information, how do you proceed? As you take out an ovary and send it to pathology for frozen section, if you have capabilities for that, how do you proceed? And all that, it's important to discuss that and document. So if you are taking the patient to the operating room, so let's say it's an ORADs 3. So let's say it's an ORAD 3 tumor, and you're taking the patient to the OR with normal tumor markers. What do you discuss with them? And it's important, obviously, to discuss. It's going by itself. Sorry. So excise the pelvic mass. Do you take out the other ovary, depending on patient age, patient wishes, fertility? Do you also do a hysterectomy? Are there other risk factors? Are there other symptomatic conditions that the patient has, such as fibroids or menometorrhagia, that you could also address at the same time? Would you send the ovary for frozen section? Do you have a frozen pathologist who can do that? And if you do you have a gyn-onc who potentially could be on standby, that if it is malignant, is the plan to address it at the same time? Is the patient ready and interested in having the full surgery based on frozen section? Frozen section at most cancer centers is about 90% accurate. So I always tell the patients, if they do see cancer on a frozen section, it's present. There is a malignancy. You cannot unring the bell. So once there's a tumor that's been seen that's cancerous, it is cancer. But sometimes the details are different. They obviously don't have the capabilities to do IHCs and other tests during the frozen section. So it may not be ovarian. It could be ovarian, but low grade. It could be mucinous, could be endometrioid. The staging is different. Do we commit to doing a BSO HIST in a young person based on a frozen section? So those are important conversations. Do you do nodes, pelvic parodic nodes? That increases the morbidity. Or do you just get the diagnosis, wait for the final, and then if it's malignant, have a second operation? Both appropriate as long as it's a shared decision-making between the patient and yourself. If the mass is unquestionably benign, what do you do? And that, again, between you and the patient, do you conserve or remove the other adnexa and the uterus? If the mass is unquestionably malignant, do you then plan to do a full staging? I think most people would probably not do that because that really ruins your OR day. If you plan the surgery for an hour versus 3, and it becomes, do we do everything all at once? If the diagnosis is uncertain, most of us would not proceed without knowing exactly what the best next steps are, and would recommend a 2-step approach: remove the contralateral adnexa versus delay completion of surgery if it's malignant. And we often say to patients, if the mass is very large and you do a laparotomy to remove it, and if it is malignant, you can go back with MIS approach and then do a smaller incision to do the full staging. When you take somebody to the OR, intraoperative management is important. So abdominal survey is probably the most important, and documentation is critical. Every time we get a referral for somebody who had surgery, the detail of the operative report is most helpful to us, and we really appreciate the details of what you saw surgically. The CAT scans are very helpful, but your observations are critical, and that's very, very helpful to us. So anything you see that's concerning, it would be very helpful to document. A cytology, do that at the beginning. If they're negative, great. If they're positive, that's also very helpful. Methodical survey, document upper abdomen, omentum, diaphragm, appendix, and anything else that you see that's concerning. If there's anything suspicious, biopsy that. That's very helpful. And then if you have access to a video or pictures from your surgery, if there's a diagnosis of malignancy, that would be also very good. So if you are planning to take out an adnexal mass, usually the steps, we're all familiar with them. The gonadal pedicles, usually the ovarian vessels that come from the aorta and the IVC, and they cross over the pelvic brim, so isolating them. We usually go into the retroperitoneum because that allows you to really get good access to the vessels and resect the peritoneum adjacent to them, avoid leaving any ovarian tissue behind, and of course identify and protect the ureter, and then make sure you sort of remove them as comprehensively as possible towards the uterovarian ligament and the cornua, and avoid rupture as much as you can. But that's why it's important to do the washings before we start dissecting the adnexa. In case there is a rupture, then we know if it's truly pre-operative, which is a higher stage than if it was intraoperative rupture. Management and retrieval of adnexal mass. So you can decide on the approach with the patient based on your clinical exam and the findings on imaging, laparotomy, and if you're doing a laparotomy, is it a vertical, midline, is it a fan and steel, minimally invasive, you do it laparoscopic, robotic, and again, that's a comfort level that you can decide of what works best for your patient population. Be creative with port placement, especially with larger tumors. You can go left upper quadrant, you can put 3 on the left, 1 on the right. Doesn't matter, you can do whatever works that you find will be helpful for that patient. So starting with a survey and sort of looking around and then deciding where to put the ports, which is most beneficial for that tumor. A lot of times we also don't use the bed to our advantage. So you can put the patient, of course, in lithotomy and put the bed in Trendelenburg, but you can also airplane the bed to the right, to the left. So if it's a left adnexal mass and you airplane the bed to patient right, the mass would sort of come off the pelvic sidewall, and that might help you a little bit to see more. So use whatever creativity you can to help you continue as much as possible MIS. Establish the plan for tissue retrieval. We don't recommend that you plan to morcellate or disrupt an ovarian tumor. that would not be, if it happens accidentally, it happens to all of us, but that should not be the plan, is to do it MIS and then morcellate it and remove it, because that would really limit the interpretation on scans and disseminate the tumor intraperitoneally, which is not advised. We can put it in a bag, and the bags come in 8, 10, 15 millimeter sizes. You can put it through one of the MIS ports, or you can put it through the vagina if you're doing a hyst. I often do that. If the mass is big, you disconnect the uterovarian, the cornua, and let the mass fall sort of towards the upper abdomen. Then you can do the hysterectomy without the mass in the way. And after that, once you finish the hysterectomy, you can advance the bag through the vagina and retrieve the adnexal mass, and then you can decompress the mass within the bag. If it has a cystic component, you can drain it with the Verus needle, you can drain it with a knife. Okay, hopefully it's nothing too bad. So this is to say, please don't disrupt the mass, so keep it intact. So you can bivalve the mass within the bag. So if you look at the on your left, you can see that mass has been cut in half, and that's fine because the capsule is still intact. But the picture on the right, where the mass was morcellated, is very challenging for the pathologist to be able to identify the capsule. So if you need to bivalve it to deliver it within the bag, that's something you can consider as well. If you have to do a mini laparotomy, that's reasonable as well to retrieve it intact. And I always counsel patients that either we start with a laparotomy or there's a possibility for a laparotomy if we do minimally invasive surgery. If you do see metastatic disease, so let's say despite all of the workup, there was no indication for metastases, but sometimes we do find ourselves in this situation where you look in and there's clear metastatic disease. So here, less is more, and documentation is critical. We're very, very thankful for the details that you provide. You can call from the OR. I've had a few pages intraoperatively where the gynecology surgeon is in the operating room. They see something, they call, they say, what do I do with this? Which is great, and I think that's very helpful. Or you can document what you see, take a picture, take a video if you have access to that. And then if you have a GYN oncologist at your institution, you can call them in to take a look. Tissue biopsies, ideally of metastatic disease. So if you see an omental mass, abdominal wall mass, something that is low risk but metastatic, would be very helpful because we can get a diagnosis and a stage at the same time. So you already know it's, let's say, high-grade serous ovarian cancer, and it's stage 3 based on your omental biopsy. Cytology is helpful, so you can aspirate ascites and do washings, and then limit the rest of the procedure. Do not remove the ovary that you were intending to do. Try not to disrupt too many planes. Don't say, let me open the retro, see if they have nodes. We will still take them back, either for primary debulking or for interval debulking after surgery. So documentation is the most important in this situation. So in summary, whenever you're faced with an adnexal mass, it's sort of, you use surrogate markers to say what is the likelihood that this is concerning, what is the likelihood that I should take care of the patient, or what is the likelihood that I should refer. So preoperative clinical assessment, select the appropriate investigations, refer as indicated. Thorough counseling is probably the #1 thing that we would all do with our patients. Structure the informed consent, intraoperative assessment, surgical plan, confirm the final pathology, and then refer again if needed. Thank you.
So Tama, thanks again for a great lecture and review and all of that. It's always good to hear it step by step about how to approach it. It's easy to sort of skip some of those steps. There's a question, I think.
Okay, so thanks, doctor, for your speech from the mechanism to the symptom to give us the whole picture of the ovarian cancer, since it's a really big topic. So I am gynecology oncology from Shanghai, China, and I'm tall. So I have taken notes of your review of the HIPEC recently published. So I'm wondering your view or your experience of the HIPEC in your center, like the prevalence, the efficacy, extra. Thank you.
Thank you very much. So the question is from one of our geo-oncology colleagues from Shanghai. Welcome. So the question is about HIPEC, which is obviously different topics. So HIPEC stands for hyperthermic intraperitoneal chemotherapy. So that's a treatment that we do sometimes for patients with ovarian cancer at various stages. Is your question about the secondary cytoreduction with HIPEC?
I'm curious, did you do HIPEC in your center? And if you do it, the percentage and the efficacy of the HIPEC?
So we do HIPEC in the neoadjuvant setting. So patients who have stage 3 ovarian cancer, we follow the OV HIPEC trial, so the VANGEAL study, very similar protocol. Patients who have advanced ovarian cancer, who have neoadjuvant chemotherapy, we do HIPEC, we offer HIPEC for patients, and the survival benefit is 12 months as opposed to patients who have interval debulking without HIPEC. Obviously, you're aware that there's new data about adding HIPEC after secondary debulking. So that's very new. The trial came out in November, so we have few patients who are scheduled for that procedure, so we'll see what their survival is like. But in that study, the survival benefit was 9 months, which is significant for patients who have recurrent disease.
Okay, thanks so much.
Thank you.
So Tommy, just a couple questions that came up. Are ORAD scores routinely done on every radiology report, or is it not mandatory, or how? Because how often do you see it? Do you not see it?
That's a good question. So I think it's center specific and potentially lab specific. It's not done on every report. And I often, if I want it, I have to ask for it. For MRI reports, you definitely have to ask. So I've had a few MRIs where they would delay and specifically book it at a specific location that has MRI ORADS capability, which I find is very helpful. I don't think there's a national recommendation. In countries where there's a national healthcare system, there's more recommendations towards universal ORADS reporting. So in Canada, there is a move that every radiology report for an Adnexal mass would have an ORAD score.
And you flashed up there quickly, but I didn't see that age was part of the criteria for
it's
ORAD. Not part of it. Yeah. Mm-hmm. Another question that has come up in the chat is the role of ultrasound as just routine sort of screening in an annual examination for a patient either with a family history or without a family history.
So in patients without high risk, with patients who are non-BRCA, not high risk for ovarian cancer, there's no benefit to doing routine annual ultrasounds. There have been studies, and there was a large UK study looking at ultrasound as a screening tool for ovarian cancer, and there was no benefit to that. Also, routine CA-125 is not a helpful screening test in a patient who is asymptomatic, who is not at increased risk for ovarian cancer. So unfortunately, until today, we don't have a specific screening test, such as a pap test for cervix or mammograms for breast cancer. So I would not recommend doing ultrasounds if your patient is not symptomatic.
And then in your talk, you had that slide looked at mortality after oophorectomy. And the question was it unilateral, bilateral? Did it matter with that increased mortality associated with women who had oophorectomy 35 to, I think it's 45?
35 to 45. So that study looked at patients who've had either one or both ovaries, and the hazard ratio was about 0.64. I don't know if they broke it down to menopausal versus just reduced ovarian function, but that would be good to look at.
So it didn't matter whether it was one or two?
Yeah.
Over them.
Yeah.
Okay.
Yeah, I had a question. That was an excellent lecture. And actually, I just read the ABOG article this year that said exactly the same thing you said. And it talked about the ORADs and the, how often to follow certain types of tumors, or, adnexal masses with ultrasound screening, but, or not screening, ultrasounds. But my question is, I know we're trying to detect ovarian cancer at the soonest possible point. But a lot of these things that we're following are actually benign ovarian tumors. And don't we want to take some of them out before they get too big, because they'll keep getting bigger, and they have higher risk as they get bigger of rupture or torsion or something like that. So, I mean, they don't address that at all. It's all about, hey, it's not cancerous, it's not cancerous, it's not cancerous, you can follow it. But don't we want to get out the benign ones too, if we can?
Yeah, I agree 100%, because there's two things. There's the cancer piece, which obviously is important, and that's life saving. So that's very important. So once you rule that out, then you can tell the patient, this could still be significant. This could still cause pain, bleeding, torsion. It might still need to be addressed surgically, but not from a cancer standpoint. And that's where you would sort of discuss with the patient, do you follow them for a short period of time, at which point, how long would the patient accept follow-up? When do you address it? And if you do you do a cystectomy? Do you do an oophorectomy? But it's important to rule out that it's not malignant.
Great. Well, thanks you again, Time. It was a great lecture, and really appreciate all the teaching that you did for us today.